12:30 p.m. on the East Coast. So if you're joining us live, you'll be able to participate in a Q&A at the end of this session. If you're catching us in a pre-recorded fashion, you can post a question and the HCMA office will review it and get back to you as soon as we possibly can. And today we are going to be, in a sense, doing a launch 3 or 4 years later, because we didn't use this technology when Sanger Heart and Vascular joined the HCMA Recognized Center of Excellence family. And today we are joined by several members of the team. And on screen with me now is Dr. John Symanski, the director of the program. Welcome, John.
Good afternoon, Lisa. Great to be with you.
Happy to have you here. So let's go back in time a little bit. You know, today we're here living in COVID-19 times, but we first started working with you guys back in 2015, 16?
Right.
And so it's been a while since you've been a recognized center of excellence. So tell me a little bit about the history of the program and how it's grown.
Sure. Yeah, I've been in Charlotte for 22 years now, and I did my fellowship training at the Mayo Clinic and had the good fortune of being mentored by one of the giants in hypertrophic cardiomyopathy, Rick Nishimura. And last night you interviewed one of his other stars, Steve Amon.
Yeah.
And many of us have left Mayo, but Mayo never leaves us. So when I came to practice in Charlotte, naturally a lot of folks turned to me for information, and I saw a lot of patient referrals on HCM. Simultaneous with that, we really evolved our practice. We've always been strong in interventional cardiology and electrophysiology and pediatric cardiology. But in the last 5 or so years, we've really embraced advanced imaging technologies like cardiac MRI and CT. And we're also a national center in structural heart intervention. So with our growth and expansion in those areas, it became kind of natural. We do imaging through our cardiologists, not through radiologists. So with that expertise, we had all the ingredients of having a strong and solid HCM program. And I went to your website, learned more about it, and went through the process, and we're thrilled to be affiliated with the Hypertrophic Cardiomyopathy Association. It's been a great partnership.
So that was, I can remember early days hearing this name of this doctor in North Carolina who actually was getting management done right. And then I get an email from this guy saying, we're interested in becoming a center. And I said, this is fantastic because I've heard this name from a few people and everybody seemed to have been getting really high quality care. So we were really happy about that. And I think the first time we talked, there was maybe 120-ish patients in the program. Yeah. And how many do you have today?
Now we're over 500, and we're probably on track to get about 150 new patients this year. And I say patients, but it's patients and families. It's really a family endeavor. So we really embrace the whole entirety of the family when we are taking on a new patient. And it's a commitment on our behalf. We've been really fortunate because we've added a new member to our team. You're going to talk to Dermot Phelan, who joins us from the Cleveland Clinic. So we've been really, really fortunate to get some experts in this program.
And it's been wonderful to see it grow because while one center that I work with may have lost somebody, the HCMA doesn't lose them. We get to keep them in another location, which is the 3rd or 4th time this has happened now. So we're happy about that. So I'm going to introduce one of your partners, Joe Mishkin. I'm going to bring to the screen. We may do a little bit of some changes here, so stay with me for a second. And Joe will be here. Hello, Joe. So I'm going to leave in these silos here. So I got to move back into center frame. So Joe, why don't you tell us a little bit about yourself and your role in the program?
Sure. So I'm an advanced heart failure and transplant cardiologist by training. I've been in Charlotte for about 7 years now. And I met John, and John's background, is in electrophysiology as well. And so things really came together with his expertise and then my expertise on the heart failure side. And so it's been a really enjoyable process growing the practice together. We were able to cover the whole spectrum of HCM care, and now adding Dr. Phelan, who you'll introduce shortly as the co-director of the practice with his sports medicine background as well as his imaging specialty. It's really, really gelled.
You are building yourself a bit of a dream team there, aren't you? And we just lost Joe. I don't know what happened to his connection, but he just dropped out. So I hope he'll come back and we'll bring him back into the conversation in a moment. But at least you got the intro. So you've got an advanced heart failure program and a transplant program there, which is kind of one of our telltale signs of a really robust program. And Joe just joined us back. So we're going to bring him back again. And he's going to be back in just a second. And I told you that might happen. And thank you for hitting the button really fast to join us back again.
No problem.
So, you're in the field within the HCM community that is nearest and dearest to my heart these days as a transplant patient. How many transplants are you taking care of right now in your region on an annual basis?
So we perform between 20 to 27 transplants a year. And so we have, several hundred in the community that we've been managing. The Sanger Heart and Vascular Institute has been performing heart transplants since the mid-1980s. So it's a large program. Over the past year, we've transplanted 3 patients with hypertrophic cardiomyopathy. And there's currently a patient hospitalized right now undergoing evaluation.
So that's that 3 to 5% of us that go to transplant. And it's wonderful that they have services right in your community to stay with the continuity of care of HCM, cross over to transplant and have that cohesiveness in that family practice. So that's fantastic. Joe, I'm going to put you down at the bottom of the screen for a moment, put you on hold while we introduce the newest member of the team. So we'll have you back in just a second. And we are bringing in our transplant from the Cleveland Clinic. You may have seen him there, and now he's in North Carolina, Dr. Phelan. Hello, Dermot.
Hi, Lisa. How are you? Great to chat to you today.
Nice to have you here. So why don't you tell us a little bit about your background and your new location?
Sure. You might guess from my accent that I'm not originally from these shores, originally from Ireland, and I joined the Cleveland Clinic back in 2011. So I was there for the past 9 years. And to be honest, Lisa, I envisaged staying there for the rest of my career. Loved the Cleveland Clinic, loved working in the HCM program there with Harry Lever and with all of the crew there. Nick Madeira, phenomenal surgeon, great people. Last year I came down to visit the folks in Sanger Heart and Vascular Institute. And I was just blown away by the program, by what John has built, by what Joe has built. I just thought that this was a program I could really see myself working with. The thing that about John and Joe, I think, that is very special is just how much they truly care about their patients. And it really is as John said, a family endeavor. And so every patient is discussed in depth, and the facilities, the backup facilities that they have. John mentioned that they recently introduced MRI and CT, but I have to say it doesn't feel like that was something that came about in the last few years. Dr. Mike Elliott, who runs our MRI program, is really a thought leader on cardiac MRI. He's one of the top guys in the country. And Marcus Shearer, who runs the CT program, again, is one of the best I've seen. So it's a unique group of skills in Sanger, and I think a unique group of individuals who truly care about the people that they serve. So I'm really excited to be down here and enjoying some of the weather in Charlotte as well.
Yeah, I'm sure like next winter will be a lot easier on you than the previous ones have been. Right. When I heard that you were leaving the Cleveland Clinic, I was, saddened that we were losing somebody who has some years of experience with some great training. And then I went, oh, wait, you're going down to Sanger? We're good. So we got to keep you. On top of HCM, you also have another area of specialty. You want to talk a little bit about that?
Yeah, that's right. So in Cleveland in 2013, I set up the Sports Cardiology Center there. And so that's a huge area of interest for me, dealing with athletes with heart disease, athletes of all levels, professional down to weekend warriors and high school athletes. And so it's really an area that's fairly new to cardiology. It's only recently been recognized as its own separate subspecialty within cardiology. And it's because these individuals have very unique difficulties, unique diagnostic issues, unique management strategies. And so it kind of makes sense that there would be a subspecialty in that. This is something that Dr. Symanski has been doing for many years here in Charlotte also. So we kind of are brethren before we knew it, in that we both have very similar interests. So I think one of the where this kind of crosses over with hypertrophic cardiomyopathy, Lisa, as you know, is that unfortunately hypertrophic cardiomyopathy is one of the highest causes of sudden cardiac death in young athletes. And athletes, when they exercise and train very vigorously, they do develop changes in the heart muscle that are normal physiologic adaptations. Like when you work out in the gym, you build up the other muscles in your body. The heart muscle also adapts, and unfortunately sometimes that adaptation can look like hypertrophic cardiomyopathy, and so it can be a real challenge sometimes to tease that out. And so that's
those knowledge bases are really, really important, especially when you're looking for that athlete's heart versus HCM. I could tell you about 10 to 15% of our population had been told at one time, oh, you just have an athlete's heart.
Yeah.
There's a big difference, isn't there?
Yeah, and on the other end of the spectrum, you do get people who are told that they have HOCM and it's actually athlete's heart. And so they're being treated when they really don't need to be treated. So it goes both ways, unfortunately. So I think that that's where you really need to have some experience and also rely on some people like Dr. Elliott and Dr. Shearer and some of these imagers to figure this out. So I think there's a great synergy between those two specialties, sports and hypertrophic cardiomyopathy.
I couldn't agree more. And there's a few programs around the country that have a very similar co-director or directorship. Matt Martinez is one that comes to mind, who's now in Morristown. So there's that crossover between sports and sports cardiology. And now I'm even seeing some cardio oncology crossovers as well. So there's things that happen to the heart that are not typical. And it's really great that you have these subspecialties. I'm going to bring Joe back up into the screen. So we're going to put on the Brady Bunch version. Don't worry, there's only going to be 4. So you don't have to. I know we've all been Zoom meetinged out where we have these little tiny squares, but now we can see everybody here with us. And I'm going to start with asking some basic questions, but if anybody has anything that they would like to ask the physicians, you can put your question up in the comments box and we'll bring it to the screen. We do have a pressing question right now, which we'll start off with, and then I'll get into my questioning. So Dermot, I guess there is some dialect issues that Tim is picking up. He wants to know if it's North or Republic, that you sounded like Republic. So that controversy to rest.
It's Republic.
Okay.
Vitally important question. Good, thanks.
So yes, there you go. I just thought we'd start off with something fun. And
we're teaching him a Southern dialect when he gets down here.
We'll make him,
He'll have a Southern drawl next year.
So Sean's saying hi, that she thinks you guys are awesome. So you've got, and Dermot's getting somebody from Abby saying hi. So there you go. So we just have some hellos and some check-ins right now. But what I want to talk about is, how is this program functioning? You know, how do patients get into you? Who gets the referral first? Is there a system that people should think about when making an appointment? How does the system work?
I'll start, Lisa. You know, we still, much of our office visits have been put on virtual mode. So we are FaceTiming, telephone visits, so we can at least do a preliminary evaluation, family history, get clinical background information on patients. And in certain situations now, we're starting to liberalize some of our outpatient testing procedures. We're still not back to real-time face-to-face visits. That's probably going to come at the end of the month. We're gradually starting to transition back to that. But for now, we're trying to do everything virtually, both for protecting patients and our staff.
Now, in terms of COVID in North Carolina, how have you guys been hit at the hospital? Have you had any HCM patients with COVID at this point? What can you tell us?
Yeah. In the state of North Carolina, we're close to approaching 10,000 diagnosed cases. In Charlotte and the Mecklenburg County area, about 1,500 that have been diagnosed. The mortality rate has remained pretty low, about 3%. And it looks like we are passing our peak in terms of diagnosed cases. We're not ready to let our guards down yet, but I think all of the measures that have been implemented with social distancing have been highly effective at reducing the surge. But certainly we're not out of the woods yet, and we have to be cautious.
Just out of curiosity, going back down to Joe here, have you seen any impact on the transplant community with regard to COVID?
Great question, Lisa. Certainly we've taken a high level of precaution with our immunosuppressed patients. We've adjusted our follow-up and surveillance visits, moved 95% of the visits to virtual visits. We've maintained their immunosuppression at specific levels to avoid the need for elective biopsies, so they don't need to come into the hospital setting and have that exposure. So far, we've been very fortunate through education. Our patients have done an excellent job of social distancing, following the CDC guidelines. We have not had any of our transplant patients contract the virus in the Charlotte area. Patients who are hospitalized with advanced heart failure undergoing evaluation right now, it is a complex process. It's always difficult, to find that acceptable donor match, but now we're having to deal with COVID testing in not only the donor, but the recipient, and taking precautions with our procurement teams and things like that.
Take a complicated situation and make it even more so complicated, it seems.
Correct.
And in terms of, just out of curiosity, going forward, how are we going to deal with COVID, antibodies? Are we going to have to add that to the repertoire of matching? Are you have to match for COVID?
Right. That's an outstanding question. And the truth is, we don't know just yet. Some of the data that we're seeing in people who have developed antibodies that can be measured, it's not clear that completely infers immunity. And we're seeing reports of people who have become reinfected. So I think the jury's still out on that and how we'll be matching donors and recipients in the future, though I suspect this will turn out to be similar to influenza. It'll be a recurring virus that's now in our environment that, hopefully we'll have a vaccine for in the near future, and then we'll have to manage it appropriately.
That's excellent. Okay, so we have a question from Brian. This is just a general COVID and obstructive question. If you had a myectomy, are you at lower risk of poor outcomes to COVID versus somebody that has obstruction? So do you think obstruction actually adds to risk for COVID? Whoever wants to take it can take it.
Yeah, I think it's a little bit like what Joe said there. The answer is that we don't have data to guide us on these kind of questions. And I think the advice that we would give would be, whether you've had a myectomy or not, that you follow all of the directions that the CDC have given us in terms of social distancing. And I think for our hypertrophic cardiomyopathy patients, we are really emphasizing that the fact that data that we do have suggests that people who have underlying cardiac conditions are at quite a bit higher risk. We don't have data. Does that apply directly to the hypertrophic cardiomyopathy population? Even less within subsets of that population. But I think the advice would be to just everyone take those precautions and make sure that they stay safe.
I think that's an excellent point. I've had a couple people, call the HCM and say, I'm obstructed. I really can't ever go back to work. I've got to stay in a bubble forever. Like, okay, the reality is a lot of us are going to get COVID. Yeah. Some of us may never even know we've had COVID. And we do have a number of patients that the HCMA has knowledge of that have HCM, had COVID. They got really sick. They had a miserable 2 weeks and they didn't go to the hospital. They survived and they're doing well, thank God. We know that each person has their own profile, and we don't even know who's all doing well and doing badly from this because it's so confusing right now. So we're hoping to get some clarity on that. I know there's a few programs around the country that are collecting data. We have one survey that we've pushed out, and there's a couple of other ones going around, so that maybe we can track this and understand in the future what we should do about these types of viruses. So we got that. Okay, we don't have any questions pending right now. So I'm going to play kind of round robin here. And I'm going to let people get to know you guys in a different way. Uh-huh. So, John, you said that you trained at Mayo Clinic and you were under the tutelage of Rick Nishimura, who has trained some pretty extraordinary people around the country. And I'm happy that many of them have landed in HCM programs. But what was it that interested you about HCM to make you say, I'm going to stay in this lane?
It's a great question. When I was growing up, I had a close friend whom I played basketball with who died suddenly. And so sudden death in athletes was a big part of my upbringing. I actually, before I became a physician, this is a unique thing. My undergraduate background is in physical education. Oh. And I got a master's degree at the University of North Carolina and then decided to go to medical school. And it was during that time that a lot of the interactions that I had through my background in sports, HCM and the overlap between hypertrophic cardiomyopathy was a natural. So it really piqued my interest. And Rick Nishimura did nothing more than, give every bit of information that he could. Terrific individual whom I'm greatly indebted to.
As am I in most of the HCM community, even though they may not know who he is.
Yeah.
So that's fantastic. So now I'm going to pivot that question down to Joe. You're the failure transplant guy, which basically makes you probably the most techie of the group because you're looking at everything other than cardiac. You're looking at all of the antibodies and tissue matching and all that technical stuff. What is it that's different or unique about HCM to you?
It's a very challenging thing when it comes to advanced heart failure in the setting of HCM. It doesn't behave similar to other forms of systolic heart failure, which is when the heart doesn't squeeze very well, becomes very weak. A lot of these while that can happen in advanced HCM, the majority of the time, the heart's just becoming so stiff, it can't relax, and people really develop progressive symptoms. So there's that challenge of trying to help people feel better and then trying to determine when is it time to move on to the next step, such as transplant. And so I think it's a natural progression when you're dealing with advanced heart failure. The HCM population is unique in some respects, and it's just a very rewarding population to help care for and take them on their journey through transplant when indicated.
Yeah, it was an interesting journey, I'll tell you that much. I literally went from one day feeling okay. I was literally at the White House on one Friday, pounding my fist, trying to make change in the world in a positive way. And by the next Friday, I wasn't feeling well. And by the following Friday, I was listed for transplant. And it was a wild ride from there. But then Brandy and I, we became best buds. And thank God for donors. And it's a complicated world. It seems so easy in a sense. When you say, I'm going to go for a transplant, and then somebody sees you before and after. But that actual surgery and those 2 weeks after, man, those are some wild times. And you need to be on your game as a physician, as a nurse, and as a patient to stay on top of everything mentally and physically. It is an amazing challenge. So thank you for that work. Now, Dermot, my newest addition to the South, we do have to work on that accent. That's for sure. But, I'm a Flanagan, so I kind of like the whole, Irish thing there. So sports cardiology, HCM, I kind of get that. But clinically speaking, when did you decide that this HCM and sports cardiology, that connection, what was the aha moment for you that this was your career path?
So believe it or not, I originally went to medicine to be an orthopedic surgeon. I got lots of injuries when I was playing football and rugby as a younger guy, and so I always thought the orthopedic surgeons looked like cool guys. I wanted to be one of those. But when I got into medical school, I didn't really have much interest in that. And actually, it was really when I was studying in medical school that I got this interest in cardiology, first of all, and that kind of matched with the sports aspect of it. And once you're interested in that, obviously hypertrophic cardiomyopathy is a key component of that. And I just think it's a absolutely fascinating disease that we really have so much to still learn about. The way it manifests in so many different ways, with many people having no symptoms and a normal life expectancy by and large. And then you have the mechanical complications with obstruction, the electrical complications, the diastolic issues. There are so many facets to the disease that I think it's really a unique kind of pathology to manage. And the patients that come in, really, it's a lot of information to try and to relate to people, particularly when they get that diagnosis first, given all the different aspects to it. And I just really enjoy that teaching aspect to the family, patients and their families, and kind of going through exactly what it means to have it and then follow them up over time. So it's just it's a fascinating disease. Sometimes it's sad outcomes, but a lot of times nowadays we've got a lot of things we can do, and we can really help people.
Yeah, I think I like Barry Marin's line the best, that HCM is a contemporary and manageable disease. I love that. I think I've come up with an analogy of HCM docs compared to other docs. There are escape room people who love challenges and like to have to look for all the little details. I think our HCM community would really do well in an escape room. Number one, they'd work as a team. Number two, they'd look for the really weird clues to figure out what's going on. And I think they'd be out in record time. So I say we take the coronary artery disease folks and the HCM folks, and we put them in escape rooms, and we do a challenge. We'll win. We'll definitely win. Okay. So we have a larger question about family screening from Connie, Connie, love the filter on your Facebook image. Would you recommend family members need to be screened by a specialty center to have their initial testing, or does this test differ from a person looking at it with less of an HCM focus? I know where my preferences lie, but let's talk to the doctors. What do you guys think about screening for families? If there's a center of excellence available, is that where they should be going, or should they just go to the cardiologist down the street who has an echo machine in the office? John, I'll hit you with that one.
Yeah, I think definitely we have a unique perspective on dealing with patients with HCM and seeing how different the manifestations can be. So there are a lot of details in the history, the family that we look for that may be overlooked. Like you had mentioned before, patients coming in with shortness of breath and being told they had asthma when they in fact had HCM. So I think our experience and insights about the unique perspectives with hypertrophic cardiomyopathy lends itself to a better result. And when to appropriately apply genetic testing, it's not right for everyone. And it's not a definitive diagnostic study in all cases, which is part of the challenge as well. So that's my perspective. I'd be interested in hearing Dermot and Joe.
Okay, Dermot, you're up. What do you think?
Yeah, I completely agree. As the disease manifests very early, there can be very subtle clues on the ECG, subtle clues on the echo We now have newer technologies and echocardiography with strain, which is not prime time, but there are things that we can look at when you are focused on that. Many people, excellent cardiologists in their own right, just are not attuned to that because they so rarely see someone with hypertrophic cardiomyopathy, so they may miss those subtleties. Mm-hmm. So, it's not available for everyone, people don't have specialty centers that they can reach easily everywhere, but if it is available, I certainly would agree with doing that. And I also think in the future, one of the things that have come out of this COVID pandemic is the use of virtual visits. And so for those people who can't actually physically get to the center but can get their ECGs and echoes done locally, I think that's a role that they'll be able. That's where virtual care will be able to come in, where they'll be able to potentially send it to someone like Dr. Symanski, Dr. Mishkin, or I, and review those ECG and echo and decide where to go from there.
Exactly. Joe, I'm just going to tag in on that one and kind of lean this more towards the heart failure side. While Connie's asking about general HCM screening, do you think that in certain cases, and I've experienced this to a small degree, when somebody's going in for transplant and they don't really know their family history, but then you find out that there's other hints in the background, it can help you guide where patients might be headed if you know what's going on there. So to understand very mild changes in an EKG during screening or echo changes in a screening, do you think that helps you figure out pathways and gives you more information as a center of excellence versus the community doc who just says, yeah, it's a little weird?
I think that's a great point. I think the history, and particularly the family history, is very important. And really what that takes is time, and patients really teasing out what's been going on with the family. We've certainly had patients present to us with advanced heart failure that it was unknown what their underlying disease process was beforehand. But then once we start getting the family history, we start seeing, oh, hey, my brother had a defibrillator, I had a nephew who died suddenly. All this starts coming to light. And then we're able to bring in our imaging experts, our geneticists, and really put the whole picture together. So I think that's a really good point, and part of the advantages of being at a center of excellence.
Yeah, I mean, for those of you who don't understand the daily functioning of a center of excellence, here you have 3 team members. And if one of you shows up in the office and something is unusual, perplexing, questionable as to how it should be managed, you've got 3 right here. And then there are others who are going to debate this amongst themselves, share their best experiences, share the patient experience and volume that they've had in their own training experience and within this center, and you're going to get a robust answer. Or you can go to the guy down the street who sees 6 people a year like you and hope that he's got it right. So I'm going with the team. I think more is better. But that's, hello, my daughter's going to pop in behind while we're live. Bye. You're going to the farm. Okay, bye. She may be 24, but she's still a kid that popped into mom's work. Okay. So, yeah, she's working from home as well. She's off. Okay. So we do have a couple of other questions. I'm going to pop up here. Sean has a question. Our symptoms vary so greatly person to person. When we do experience a new symptom for that individual, when do they call? When do they communicate those new symptoms to their team? Are there things that should wait for the annual appointment, or are there things that should precipitate them picking up the phone right away and letting you know what's happening? John, we'll start with you.
Another great application for virtual technology. I think when you address symptoms sooner rather than later, you're more likely to have a favorable impact rather than waiting for too late. So we now have so many methodologies for screening. We have advanced practice providers who can also answer questions for patients. If it sounds like something really in need, we can get them in to be seen. So you don't want to be overreactionary, but nevertheless, you don't want to ignore symptoms that persist for more than a few days. So I think earlier is better.
Yeah, and just to chime in on that as well, I think that's where the education part of it really comes in as well, doesn't it? During that initial visit, because we all get little nags, little pains here and there. We all get various kind of symptoms, and it's very hard when you get a diagnosis to differentiate. And all of a sudden, all of those things that we used to get that is just normal, a part of life, suddenly takes on a different meaning when you've been given a diagnosis like hypertrophic cardiomyopathy. So kind of talking through, on those initial visits, what are the kind of real symptoms that we're paying attention to, and ones that we need to know about. I mean, I think the sudden fainting episode is one where, you kind of say, okay, you need to call us immediately. And that's something that you don't want to wait for your annual visit. That's something I need to know about straight away. So I think spending the time and going through all of that is really key at those kind of initial visits.
I couldn't agree more. I would also say that the first 2 years of diagnosis, there's a lot going on physically and emotionally, and just understanding your body in a new way. For the majority of people with HCM, you've probably had an abnormal heart since adolescence, and you've learned to acclimate to it, and it seems normal to you until they tell you there's something wrong with your heart, and then you feel every PVC, and if your blood pressure shifts the slightest bit, you're, okay, that's it, I'm out of here. And you go through this cascade of adrenaline every time a little symptom pops up, and that's really, really normal for the first 2 years. So I would keep logs and try to track, does this happen with food? Does this happen with lack of sleep? Does this happen if I have something to drink, alcoholic, or what is happening here? If you keep that log and you get to know you a little bit better, you become in tune with your body. And when something goes out of that norm, you need to communicate it. Some physicians choose email, some want a phone call, some will get a telemedicine appointment with you. So depending upon what your center prefers, communicate as clearly as you can, as fully as you can, normal to abnormal. So when there are big shifts, we can deal with them. When there's little shifts, we can deal with them. But you really need to have a plan in advance. And if you've been watching these video sessions over the past couple of sessions, you've heard me mention, have a plan. Know when to communicate. Talk to your center about that in advance. So you shouldn't be worried, when do I do it? You should kind of know where the line is and have a plan in place. I found that really specific in my transplant journey. When I moved from being an HCM patient to a transplant patient, I kind of went back in time to those first years of diagnosis, and I was calling the transplant center. Is this normal? Is this normal? Should I do this on milrinone? Should I act like this? And they're like, you're okay. I'm like, oh, I'm a newbie again. And you start all over again in a whole different pathway. So we have a question about surgery numbers. I'm not 100% sure what he means by this question, or she, sorry, but we'll ask this. Would there be more numbers of surgeries performed if they were minimally invasive? Okay, so she's talking about a minimally invasive surgical approach. Okay. Do you think we would do more surgeries if it didn't require a thoracotomy, I guess is the question. I don't necessarily know that that's a viable question because it's not a technique that we can really use. So let's talk about new approaches to surgery. Do you think anything's coming down the pike?
Well, one important technology, I wouldn't necessarily call it a surgical approach, but an invasive technique, is something called a MitraClip. And this is specifically for patients with bad obstruction, largely due to elongated mitral leaflets and structural abnormalities in the mitral valve. And the theory behind this is that by plicating or clipping the anterior mitral leaflet to the posterior leaflet, you can prevent it from going into the LV outflow tract and resulting in outflow obstruction. Small published series to date look favorable. This is not a first-line therapy. It's not going to replace myectomy, but for select patients, this may be an option. We also need to mention alcohol septal ablation. We are not a large volume center in that technology. We have the expertise for doing it. Jonathan Schwartz, who joined us a few years back, trained at Stanford and Minneapolis Heart Institute, and Jonathan does alcohol septal ablations. I'm dating myself, but Jonathan's father was actually one of my mentors at Mayo as well. So the family cycle continues.
It seems to happen that way in cardiology. You follow in the footsteps of the fathers and the mothers. So I just want to talk about mitral clip for a little bit. So some of the early data on that was from Paul Saraja, formerly of Mayo, now at Minneapolis Heart. And he did a series of individuals who were elderly, 75, 80 and older. And it did look like it could be a viable option. But I think some of the controversy there lands with, can you put a clip in somebody much younger in their 40s or 50s? And what are the long-term implications of that clip in place? And I don't know that we are going to go there when we can clip, do a surgical clip on that valve.
Yeah, we don't have that answer yet. Obviously, younger patients who are good surgical candidates, myectomy, an open heart procedure is still the best option. But for those patients who are not good surgical candidates due to coexisting lung disease or other comorbidities, this may be an option.
Absolutely.
It's a question I guess we get every time we have a patient that we're talking about myectomy with, because everyone wants to have a less invasive option, right? I mean, if you can do it less invasively, why not do it that way? And people talk also about doing the surgery using robotic technique as opposed to a full sternotomy. And my answer there is that the sternotomy, it's scary, it sounds scary, but the reality is that it's incredibly successful. And it when you have patients that are profoundly symptomatic and you send them for a myectomy and they come back, weeks later and they feel 100 times better, it's incredibly gratifying as a physician. It sounds strange to say that, sending someone to surgery, but it is, because they really do so well most of the time. So I try to, it's hard to go and use more, investigational technology when you've got such a good option already on the table that we've got lots of experience with. Dr. Larry Watts here in Sanger has a vast experience doing myectomies, and the results are just, incredible. So I try to reassure people that, this is in the right hands. Very much, this is where you really do need to be in a center of excellence. In the right hands, where people have experience doing myectomies and do a good volume of them. This is an incredibly successful surgery with a low risk.
Couldn't agree more. I know people are afraid of thoracotomies. I was too. Didn't have a myectomy, just got rid of the heart. Still the same procedure. Still have to break that rib or that sternum and get in there. But I have to tell you, except for on very rare occasions when I sleep bad, I'm 3.5 years out. Don't even know that it was there, and I have hardly any scar. So silicone stick and bio oil, because vanity matters. It worked for me, so that works. Okay, we're going to wrap up with one or two questions here. So I think I'm pronouncing her name right, Rushi. If I pronounce that wrong, I'm sorry. You're referencing Paul Saraja's literature on IRE ablation. Any thoughts on that? So doing a radiofrequency ablation for outflow tract obstruction. What do we think?
There's limited data on this technology. There was a recent publication in the Journal of American College of Cardiology that came out of China. And I'm always a little bit leery of the Chinese data until it's replicated in another renowned center.
Yeah.
It looked promising in their preliminary data, but again, I think we need more information before we can make this a recommendation.
I would agree. And for whatever the reason, people are very interested in other ways of dealing with obstruction.
Yeah.
I mean, the early days of alcohol septal ablation actually came from an article that Barry Marin published back in the 80s about a patient of his who happened to have an infarct in the septum at the first septal perforator, and it got rid of his obstruction. Well, I got rid of my obstruction too, but I would not recommend that everybody go out and get endocarditis, get scar tissue on the anterior leaflet of your mitral valve, pushing it out of the way and getting rid of obstruction that way. A myectomy probably would have been a lot easier and saved me from having a stroke. But we find these neat things about the anatomy that can change things. At the end of the day, obstruction is bad. We know myectomy has worked for over 40 years. Alcohol ablation is an alternative for some patients, but not most. And rather than focusing all of our efforts on another way to get rid of obstruction, I love what we're doing with drugs like mavacamten, looking at how do we change the heart in its entirety and how do we make it function more normally and deal with the whole heart. Because some patients think, I had obstructive HCM, I got rid of the obstruction, I'm out, I'm done, I don't have HCM anymore. Gentlemen, is that true?
No, that's not true. And we believe, and we've seen data that suggests that sudden death risk is lessened or mitigated by septal reduction techniques. But we can't be guaranteed that that's absolutely the case. So we still have to be vigilant and screening for those. We're really excited about the possibilities with some of the myosin modulators. You mentioned mavacamten. Mm-hmm. So, we haven't had good new medical therapies for many years in HCM, and they're desperately needed. Many of our patients are not happy with the results with beta blockers or calcium channel blockers. So this is the first new iteration, and we're really excited about the possibilities.
Now that you mention that, I'm going to take the opportunity to remind everybody that June 26th, the HCMA will be holding a patient-focused drug development meeting with the FDA present, and patients will have the opportunity to tell the FDA and drug manufacturers directly. It will be a virtual meeting. You can all log in. You can use our phone in line to share your thoughts and experiences with HCM so that the FDA knows what it's like to live with HCM and knows what symptoms that the medications people are developing should be addressing, and what would be a meaningful drug to you or a therapy to you. And if we have this opportunity, you only get this one once, ladies and gentlemen, and June 26th, it's yours. You can talk directly to the FDA, share your thoughts, and become part of the literature that drug manufacturers will utilize in the future to help develop new drugs for us. So you can register right now at 4hcm.org, and you can just sign up. You can participate with us online. You can use your phone in. You'll be watching us live. It's going to be an amazing event, and we need you all to participate. And I'm going to leave with one last question, and it's a complicated one. And George, I'm going to hit your question, not quite in the detail that you went into here, but what if you're an HCM patient who has had experience with bilateral pneumonia on top of your HCM, and you're living through all things COVID, and it's time for your kids to go back to school? How do you keep yourself safe from your child who is likely going to become affected in a school environment? Should somebody like this, self-isolate in the home? Any tips or thoughts for somebody in this kind of a situation? We're all heading there now. The world's opening back up, and we're going to get more COVID before we get less. Any thoughts?
Wow, incredibly complex question, and a tough one. I mean, as providers, we were all fearful about not only us getting it, but giving it to our family. And I think that's a real concern. We're all praying and hoping for the development of a vaccine as soon as possible. In the interim, certainly hand hygiene. You don't want to totally distance. We want a social distance, but not emotionally distance from our family, right, which is incredibly important. And we hope we'll have more testing, looking at patients who are potentially immune because of asymptomatic infections, but a really difficult scenario. Dermot, you're a father of 4 now.
Yeah, no, it's a really tough question. I don't think anyone has a good answer. I mean, we think about this kind of personally as well. As John says, we're all doctors going into the hospital each day treating patients and then coming back to our own families. So it's a little bit like the analogy of the children going to school, and many of us have loved ones at home who have chronic illnesses, and so we struggle with this ourselves as a community, and there is no right answer. I think being as cautious as you can, as John said, in terms of the hand hygiene, potentially when the kids come in from school, certainly when I come in from work, shower and clean off and wash everything as much as possible. But there's no good solution or answer to that. As John says, it's really following those guidelines and hoping that we do get a definitive treatment for this or vaccine soon. I
think being a transplant patient has taught me a lot about how to try to keep myself socially distanced for the past 3+ years. I'm personally liking the way that the airlines are taking this on now. I don't have to get on and sanitize my own seat. Everybody will be wearing a mask now on airplanes. And I think we're moving to the next part of the world, which is, I think that the heart failure and transplant world should be educating everybody on how to wash their produce, on how to do good hand hygiene, on how to make sure that you're not coming too close in contact with somebody who appears to be sick. And all of the things that I learned in the pre-transplant process, I'm actually teaching people as we go forward that we really should all be doing the same things, because these viruses are highly contagious. So Joe, we actually have a final parting question for you. And I'm going to put you on the spot. Somebody noticed your guitar, and I want to know if we're getting a concert.
Well, I'd love to, but I've got my virtual clinic patient waiting right now. So
and there you go. And
we'll have to pass. Yeah.
Okay. We might call you back for another day on that one.
That'd be fine.
And we'll do an online concert. That would be fun. All right, guys, I want to thank you all for your time today. I'm sure our audience got a lot of insight on the Sanger Heart and Vascular HCM program. We thank you for your time, and thank you all for your great questions today. And thanks so much.
Thank you so much, Lisa.
Thank you, Lisa.
Thank you, Lisa.
Okay,
take care.
And boom.